morning, everyone from the American Southwest. My name is Dr. Josh Bloomstone, and I must say that moderating this session is certainly the highlight, actually, of my career. For those of you who I haven't had the pleasure to meet, I serve as Envision Healthcare Senior Vice President for Clinical Innovation and Clinical and Practice Transformation. And I also serve as our clinician lead for the Envision Research Institute. Now, my own research interests into both perioperative risk prediction and perioperative outcomes have really afforded me the honor, have allowed me the honor of crossing paths with two exemplary individuals, two exemplary clinician leaders, and two exemplary clinician scientists in Drs. Ramani Moonesinghe and Kamal Maheshwari. Now, briefly, Dr. Moonesinghe is professor of perioperative medicine at the University College London and honorary consultant in anesthesia, perioperative medicine, and critical care at UCL hospitals in the UK. As many of you know, she is the current National Clinical Director for Critical Care and Perioperative Care at the NHS England and Director of Health Services Research Centre at the Royal College of Anaesthetists. Her research focuses on evaluating novel technologies and pathways, risk prediction, and patient outcome measurement and improvement studies focusing on perioperative and critical care. Dr. Kamal Maheshwari is a staff anesthesiologist in liver transplant and acute pain management at the Cleveland Clinic Foundation and clinical associate professor of anesthesiology at the Cleveland Clinic Lerner College of Medicine. Kamal also holds an MPH, which he obtained from Johns Hopkins Bloomberg School of Public Health, and specializes in health policy and management. Kamal's area of research, as many of you know, focuses on perioperative outcomes and the critical role that perioperative hemodynamic optimization plays. Now, before we dive into these fabulous lectures, just a few housekeeping notes. We're going to start with a recorded session from Dr. Maheshwari, then go live with Dr. Moonesinghe, and end live with both speakers in a Q&A session. I want to thank you all for everything you do, and I'd like to thank Drs. Moonesinghe and Maheshwari for their exemplary contributions and for being with us today. Let's begin with Kamal's recorded lecture.
Good afternoon, everyone. Today, I'll be talking about, does risk prediction improve patient outcomes? First of all, I would like to thank Association of University Anesthesiologists for the kind invitation, and I'm honored to participate in this discussion. I'm an anesthesiologist at Cleveland Clinic, work in the liver transplant division, and from disclosure point of view, I have funded research from Edward Life Sciences, and I'm a consultant with DynoCardia. Learning objectives is to describe various preoperative risk prediction model, which the rest of the panel speakers will also talk about. Primarily to identify clinical decisions, which is influenced by use of risk prediction model, and assess improvement in patient outcomes with the use of risk prediction models. First, how does risk prediction work? So any model of risk prediction has an input data. The input information can be as simple as age or any clinical exam information. Based on that information, there's some processing or some modeling which happens. And that can be as simple as some scoring based on that if you have one or two risk factors, or it can be a complex machine learning models in which advanced machine learning algorithms is used. Based on this processing, there's a specified output. The output, again, is that you classify a particular patient into, or a patient group into a group which is high versus low risk group, or the output could be a specific prediction. For example, it can be a prediction of mortality that based on this information, the prediction model is saying the mortality risk is 1.4%, as specific as that. And then comes the outcome part, which is oftentimes missed. When we get the output of our model or risk prediction model, we say that, okay, the output is good, and that's why the risk prediction is good. But outcome is patient outcome. Does the use of risk prediction model or this information help improve patient outcomes? Help improve, for example, patient satisfaction? For example, help reduce patient mortality, or help reduce kidney injury in that patient? And that is the important component which we are talking about in this discussion. The input of age, sex, comorbidities, and multiple other factors. Albumin, hemoglobin values which goes into the model, algorithms which gets processed, your classification, and your actual outcome improvement, which we are interested in, get decided. So my goal is not to go over the literature and tell that each and every study what they did or not. The goal here is to understand how risk models are developed and how they are used, and can they impact patient outcomes. So let's take an example of classification models like American Society of Anesthesiologists physical status model. We classify ASA 1, 2, 3. These are one of the most common risk models which is used. What we are trying to assess is the patient is sick or not, and how sick or not. It was originally used for to help identify the patient which will require more resources and ultimately lead to higher billing. But it is the most commonly used models which tells us that if the patient is sick or not. Similarly, Mallampati score, in which we do a clinical exam and we assign the patient into a difficult airway category. And so this information helps us identify or available resources for that particular case, how to manage that patient, and in our anesthetic plan, right? But just identifying a patient who is sick or identifying a patient who has a difficult airway doesn't mean that it's going to improve outcomes. It does mean that if you appropriately manage that patient using this as a risk information, the outcomes can be improved. Then we commonly use risk prediction models, which is revised cardiac risk index, in which based on 6 different criteria, we identify patient into low, moderate, and high risk, and then they are associated with a certain probability of major adverse cardiovascular event. That's the outcome which the risk is predicting. Risk stratification index is an open source, slightly complicated mathematical model. It uses ICD code, it diagnoses information, and predicts 1-year mortality, length of stay. And these are actual percentage mortality and actual length of stay, which is predicts. And then you have also have American College of Surgeons NESQIP risk prediction models, and they predict a specific post-operative complications. So understanding that what a risk prediction model uses as an input and what actual outcome it is predicting is the most important thing to get started on risk prediction. Then trying to use this information in improving patient outcome is a whole another beast. And the question what we have to ask is, what do you do with this risk information? And which clinical decisions are changed using this risk information? And as we talked, we go back to the commonly used examples, right? American Society of Anesthesiologists score. You can decide to change the level of monitoring of a patient. You can decide to change anesthesia care team, which is appropriately trained for that particular case. And that may affect patient outcomes. Similarly, Mallampati score, if you identify a patient with the risk of difficult airway, you can use a specialized airway team or equipments, and you use a specialized airway management planning. And if you do that, the chances of optimal airway management is high, and ultimately patient outcomes are better. So let's go into detail of one of the common predictive risk model, which is American College of Surgeons. I'm just taking only few examples just to go through the motion that how these are generated and then how we use it. So for example, if you, in this case, I inputted the information that the patient is going for a cholecystectomy, and it's a younger patient, female patient who just have one risk, which is oral diabetes, is taking oral medication for diabetes. And if there's no other risk factors, what comes as an output of that model is that here is the chances of complications, which are specific complications for this patient. And these are, given that this was a comparatively healthier, younger patient who has only one or two risk factors, it came out to be, has on an average risk of any complications, average risk of readmission, death, surgical site inflammation, and length of stay is 3 days. So this model is good, it predicts well, it's validated, but the question is, you have this information, what you're going to do with it? And that will decide, does it help improve patient outcomes? Let's change this criteria in this particular patient, that same surgery, but now it's in an older patient with ASA class 4, diabetes, smoker, multiple risk factors. Now you know that the chances of patient cardiac complication is high, the chances of surgical site infection is high, chances of readmission is high. Now you have this information, then again the question is, what are you going to do with it? So if you are able to modify any of this risk for complication, then you can say, yes, this risk prediction helped improve patient outcomes. Same question again, which I'm trying to get at is that even if the well-validated and calibrated risk models which are available, simple or complex, use of the risk information and how you use it in patient care is important, and the clinical decisions which get changed with the risk information is important. Here's an example for AKI prevention, acute kidney injury prevention. For example, in the last few slides, I show a high-risk patient who has a high risk of kidney injury. So what can you do for prevention of kidney injury in that patient? Then we know the risk factors. The model is predicting. Here on the left side of the screen, you have a patient who's going for a surgery with multiple comorbidities, and there are numerous risk models which are going to say that yes, the patient is a high risk of AKI, right? But when it happens, what can you do about it? So this recent paper is kind of a review article which went through that for AKI prevention, what can be done, and if AKI happens, then what should be done? So for stage 1 and stage 2 AKI, the chances are that you don't need dialysis, and you monitor the patient with appropriate blood pressure management, with reinitiation of ACE inhibitors timely, and close monitoring of the patient. So that's what you can do. And if you have stage 3 AKI, then likelihood that you might need dialysis and renal replacement therapy is high, and you have to kind of monitor, maybe long-term care will be provided. But knowing a patient who have high risk of AKI will be half of the equation, and then rest is how you manage that AKI. In common terms, going through the literature, we don't have a major breakthrough in AKI prevention. So far, if you look in the literature, maintaining mean arterial pressure, which is normal, Some evidence of goal-directed therapy and evidence of avoidance of nephrotoxic drug is there. So if a patient comes with a high risk of AKI, and if you focus on these interventions, the likelihood of better outcome is there. Let's talk about myocardial injury prevention. So if a risk prediction model says that patient have a high risk of myocardial injury, which is myocardial injury in non-cardiac surgery, if you go specifically into that, which is based on troponins, what you can do. So one thing is that for high-risk patient, you monitor them closely, and if the MINS or myocardial injuries develop, then electrocardiogram, echocardiogram, cardiology referrals may be needed. Maybe patient needs statin therapy, beta blockers, ACE inhibitors, or coronary revascularization. But these therapies and what should be done appropriately are not well defined in perioperative medicine. There's still work going on, and this is what I took from American Heart Association recent guidelines published by one of the work colleagues at Cleveland Clinic, and that highlights that what you can do for myocardial injury management and prevention. The other things which is there in the literature, and if you summarize that, it will be that, okay, maintain mean arterial pressure. That means avoid hypertension. Goal-directed therapy to some extent can help. Troponin monitoring, serial troponin monitoring can pick up patients who have myocardial injury early. Post-op telemetry on high-risk patients. Resuming of home meds, checking post-op ejection fraction. There's some role of pro-BNP monitoring. So what it comes down to is that if you have a high-risk patient, you have to monitor them closely and give appropriate care, and then specific appropriate care will be dependent on that individual patient. Other common complications which happen, or which we try to predict, is pulmonary complications that decides an anesthesia care plan. And in that, the potential intervention, if you get the patient who have a high risk, is that you restart the pulmonary medication inhalers. There's some role of using Sugammadex for reversal, or just ensuring that patient is neuromuscular reversal is reversed. That is there, which can happen through quantitative or qualitative neuromuscular monitoring. There's some evidence of use of continuous monitoring, like pulse oximetry or CO2 monitoring or tidal volume monitoring, which can identify the patient who have poor ventilation early than later, and then you can manage this appropriately. So in conclusion, yes, risk prediction can improve patient outcomes, but with a caveat. It is dependent on how we utilize the risk information in clinical care. Important thing is, we as anesthesia community need to define and identify individualized risk-specific care paths. And with that, I'm going to end this talk, and thanks a lot for listening.
Kamal, thank you so much for that last slide being so important. It reminds me that clearly a fundamental truth exists between risk prediction tools and patient outcomes. And that fundamental truth is that these tools do nothing to improve outcome unless they are coupled with evidence-based, individualized care pathways that focus on the risk at hand. And with that a fundamental truth in mind, Dr. Moonesinghe, I'll pass you the microphone. Thank you so much.
Thank you very much indeed, Dr. Bloomstone, and thank you to the previous speaker for that great talk. So I'm going to share my screen now. Excuse me just one moment. There we go. Dr. Bloomstone, is that coming up okay, do you think?
Yeah, looks perfect. You may want to,
okay.
Perfect, thank you.
Great, thank you very much. So Good morning, good afternoon, everyone. So I'm going to give two short talks now. The first about which tools are available to us, and then following on from that, one about the conundrum about population versus individualized risk assessment, which may spark a bit of discussion, we'll see. So which tools are available to us for perioperative risk assessment? I have no disclosures, although one of the tools that I'll present, I was involved in the development of, but I have no pecuniary interests as a result of that. So before we go into the main part of the talk, I'm just going to give a brief reminder about how we measure the accuracy of risk prediction tools generally, just in case you have forgotten. The two broadest sort of ways in which we do this are to look at both discrimination and calibration. So discrimination is usually measured using the area under the receiver operator characteristic curve. It gives you a summary statistic for the sensitivity and specificity of a prediction tool. And essentially what it does is it helps you understand how well, if you had 100 people, how well you'd be able to line them up in order of their risk. And the value of the area under the ROC curve, or the AUROC, can vary between 0.5 and 1, where 0.5 is no better than a coin flip. Up to 0.7 is moderate, 0.7 to 0.9 is good, and greater than 0.9 is so good that you almost start to wonder what's going on. Calibration, so how well the tool, the prediction that you might get from a model which gives you a percentage risk, for example, of death at 30 days or of any particular outcome, how well calibrated that is against the population that you're looking at. Now, an interesting thing about risk prediction tools and their longevity is that discrimination can change over time. For example, risk prediction tools developed in the 70s, 80s and 90s perhaps probably had a greater emphasis on the impact of cardiovascular disease than a risk prediction tool that might be developed today would have, because of the general improvements in the way that we treat patients with cardiovascular disease as a result of not just open heart surgery, but obviously percutaneous interventions, primary and secondary prevention using pharmaceutical interventions. But on the whole, discrimination is likely to remain reasonably consistent over time with that single caveat. Whereas calibration is potentially much more likely to change in the same way that you get calibration drift in your arterial lines and your central lines in the operating theatre. One might get calibration drift from a risk prediction tool. And the reason for that, happily, is largely because the quality of patient care improves over time. And that will therefore mean that tools that were developed in the 1990s will over-predict the likelihood of an adverse outcome compared to tools developed today or in populations of today. So after that sort of brief reminder of the stats, I'll go into the three main ways in which we can estimate perioperative risk. So the first is that we can use different measures of functional capacity. The second is that we can use biomarkers, and the third is that we can use scores or models. Dr. Maheshwari has talked a little bit about those in the previous talk. So functional capacity, there's a number of different ways in which you can assess it. There's the relatively straightforward way, which is asking patients to self-complete a questionnaire. We would most commonly use the Duke Activity Status Index, but there are others as well. And essentially what this does is asks the patient a few simple questions about what they are able to do in terms of day-to-day activity. Are they able to, for example, do the housework, or are they able to take part in strenuous sports like swimming or skiing? And based on the answers to those questions, you can calculate the patient's metabolic equivalence in terms of their general cardiorespiratory fitness. A next step up in terms of complexity would be something like an incremental shuttle walk test or a 6-minute walk test. So the clues are in the names. You ask a patient to walk between two posts in the case of the incremental shuttle walk test, or just for 6 minutes on a treadmill, for example. The distance that the patient walks is then compared to tables which give you an estimate again of their metabolic equivalence. Over on the right-hand side of your screen, you can see a 9-panel plot, which is the usual output from a cardiopulmonary exercise test. And many of you will have seen these. The patient usually goes on a bike, although it is possible to do it on treadmills, but bikes are preferable because they are less volitional in terms of the exercise, the ability of the patient to do the exercise. And they produce a number of different measures of cardiorespiratory fitness. The ones that we as anesthesiologists tend to hang our hats on are the anaerobic threshold and the peak oxygen consumption, but there are many others as well, as that 9-panel plot indicates, and taken together can give you a very detailed assessment of the patient's functional capacity and aerobic fitness. And then we have biomarkers, and there are some very familiar biomarkers for not just perioperative settings, but general healthcare settings. So for example, high sensitivity CRP is independently predictive of adverse cardiovascular events in general populations. N-terminal proBNP, again, predictive of adverse cardiovascular outcomes in both general populations and perioperative populations, and I'll talk about that in a little bit. And then postoperative troponin, now almost 10 years ago, the VISION study was published, which found that serial postoperative troponin measurements were independently predictive of mortality in cardiac events and major non-cardiac surgery. I'm sure you all remember seeing this graph, which demonstrated that cumulative hazard rising as a result of an increase in your peak troponin after surgery. And that's been subsequently validated in other studies as well. Now, this study in 2018 was an international multi-center study led by Daminda Wijayasundaram from Canada. And this looked at biomarkers and measures of functional capacity and compared them to each other and in order to understand which were the best predictors of adverse outcomes in patients having major non-cardiac surgery. And I'll show you a brief summary of the summary results tables. So here I'm highlighting the area under the curves, and you'll see on the left-hand side the different outcomes and the different models that were created from the different constituent measurements and the relative value of each of these different measures for different outcomes. And overall, if you remember my classification of area under the curve and how to consider the numbers, it's a little bit disappointing when you see the best area under the curves for 30-day death or myocardial infarction prediction gave you only an area under the curve of 0.67, and the best predictors of 1-year mortality gave you an area under the curve of only 0.72. So only really just starting to become of interest. This study, which was done on a subset of patients who were in the MET study, which I've just presented, who also did a 6-minute walk test, again, looked at whether that much simpler evaluation of functional capacity was able to predict different outcomes. And again, sadly, the results were a little bit underwhelming. So you can see here the prediction of disability-free survival. The DASI, so the Duke Activity Status Index, did okay, but the other measures not very well at all. 30-day death or MI, again, a bit underwhelming. 6-minute walk test, reasonable, but really not that great. And again, prediction of 12-month mortality and terminal proBNP predictive, as it is in life, of adverse cardiovascular events, perhaps reflecting that general sort of population effect that a high N-terminal proBNP has in terms of cardiovascular risk. Now, what's the reason for these slightly disappointing results in these assessments of functional capacity and biomarkers? Well, when you think about what contributes to perioperative risk, yes, there's patient health and fitness, and that's what measures of functional capacity and biomarkers are there to evaluate. But there's also the surgical urgency and magnitude. So put plainly, the frail 90-year-old patient coming for a cataract operation is very unlikely to die within 30 days of the surgery as a result of the surgery, whereas the same patient going for an abdominal aortic aneurysm repair will have a substantially higher risk of death and adverse events. It stands to reason. So then we see, therefore, how risk stratification tools or risk prediction tools come into their own that combine these different measures, the measure of functional capacity, the measure of surgical magnitude and the measure of surgical urgency together to come up with a predictive model. And as a sort of rule of thumb, if you are interested in the highest level of precision, you probably want to look for a risk model which has been tailored to the population that you serve. So if you are exclusively a cardiac anesthesiologist, you'll probably be most interested in a cardiac surgery specific risk prediction tool. In Europe, we use the Euroscore. Similarly, for trauma surgery, the Nottingham Hip Fracture Score is excellent for patients with hip fracture surgery, and the National Emergency Laparotomy Audit Model, which is used in the UK to predict outcomes from emergency laparotomy, is also excellent in that population. But most of us do different types of anesthesiology on different days of the week, and would value a more generic risk prediction tool to help us understand the risks in all the patients that we look after. Now, Dr. Maheshwari has already talked about the NISQIP surgical risk calculator, which I must say for many years has been the envy of the world, I think. Having such a seemingly precise, detailed risk calculator, which is open access, is a really fantastic resource. So I'm a big fan. I'm a big fan of it because it's open access. I'm a big fan because it's regularly recalibrated and updated. And I'm a really big fan because it predicts complications and length of stay, discharge to nursing facilities and so on, as well as the usual measure of short-term mortality. On the other hand, it's not so great in terms of the fact that it's a proprietary model. So they don't publish the equations, the coefficients that go into the model openly. Which then becomes a challenge for validation outside the NISQIP system. So although I can use it in my clinic on my patients, I actually don't know how well it performs in the UK population. And while one might assume that prediction of death or complications would be similar, we can't assume that. And we certainly can't assume that things like risk of discharge to a nursing home or length of stay would be similar across different healthcare systems. The other limitation, which is important, but perhaps a little bit picky, is that it doesn't predict currently longer term outcomes such as 6 or 12-month mortality or disability-free survival. And that it is not alone in that. I don't know of any published risk models that do predict those longer term outcomes. But that really is where we should be going. And Dr. Bloomstone, the chair for this session, asked me a question on that earlier on today. Now, we have developed in the UK something called the Surgical Outcome Risk Tool, which is a simple risk calculator that was developed on a large data set in 2014. And then subsequently in this paper in PLOS Medicine in 2020, we validated it again in an international cohort, but also we looked to compare the validity of this tool against clinical judgment, because our observation was that despite the plethora of clinical risk prediction tools available, clinicians largely rely on their own clinical judgment when they are predicting risks in patients and to guide their clinical therapy. And so we wanted to know, well, actually, how do they compare? Are clinicians better or worse than the best of the risk prediction tools that are available to us? And what we found here, and here you see a ROC curve for clinical judgment, the surgical outcome risk tool, and importantly, the two combined when we created a new model with them. And we found that we could improve the predictive value of both the sort itself and clinical judgment, and into a new tool that was significantly better than clinical judgment alone. And importantly, predominantly reclassify patients from a high risk group into a low risk group. So essentially, if relying on the sort or if relying on clinical judgment alone, clinicians might have been more likely to send their patients to critical care after surgery than perhaps would have been necessary. So our advice now in clinical guidelines in the United Kingdom is that we should use the original sort if the assessment is being done by less experienced colleagues or by patients indeed. But if you're an experienced colleague, or ideally a multidisciplinary team doing a holistic risk assessment of the patients, then the sort clinical judgment model is the best approach. So in summary, if you want to use a risk prediction tool, there's plenty of options available to you. Risk models which incorporate both patient and surgical factors are the most likely to give you accurate estimates. But in truth, I think that we need to worry a little bit less about which tool to use and more about how we use them responsibly. And I think I'm going to come on to talk about that in just a moment. Back to you, Josh.
Thank you, Professor Moonesinghe, and thank you for the various comments in the chat as you're changing slide decks up. I'm going to offer a small challenge, but first, I just want to say that relative to the surgical risk calculator, while we can poke at various frailties of the calculator itself, it is an amazing tool that really the American College of Surgeons should be congratulated for continually improving, including the recent addition, not only of pediatric outcomes data, but also information from the geriatric verification program and enhancing its risk prediction capabilities relative to frail patients. Here's the challenge. In 2013, Dr. Moonesinghe published a beautiful review of risk tools at the time in anesthesiology, in which she said clearly, we do not know how many people actually use these tools. And a tremendous amount of work, a tremendous amount of money has been put in to the creation of these tools. Our team and Dr. Moonesinghe helped us with this, looked at 140,000 patients in 5 different states, many of whom had very severe outcomes. We looked at the documentation of both anesthesiologists and surgeons to see, were these tools being used? Was the use of these tools documented in any way? And what we found was that in patients with severe outcomes, only 4 out of 100 anesthesiologists had documented the use of any risk modification or risk prediction tool. And surprisingly, 4 times that number of surgeons actually documented organ-specific risk. With that, I'm going to challenge everyone on this call to use these tools to document their use and to document the discussion that happens with patients relative to the results these tools give. Professor Moonesinghe, back to you.
Thank you very much, Dr. Bloomstone. So I'm going to now share my screen again. Okay, so individualized versus population-based estimates. Is there really any difference? Okay, so my disclosures are the same as before. I have no financial disclosures, but the association with the surgical outcome risk tool, which I've already declared. So populations versus individuals, what's the right approach? Okay, so how can we do this? We can focus, for example, on high-risk populations. We can say, okay, by patient characteristics, everybody over the age of 80 is, or 70 is high risk, or everyone with more than 3 comorbidities, or everyone with a frailty score of greater than whatever. We could look at surgical magnitude. So we could say, right, everybody having cardiac surgery is high risk and must have a particular pathway of care, or everyone having emergency surgery, emergency abdominal surgery, for example, is high risk, and go for it that way. So just focusing on population level characteristics. Now, I'd suggest that that's the wrong way to think about it, because of course, sometimes people surprise us. And although we might consider that most of the patients over the age of 80 would look a little bit more like the lady on the left, once in a while, we might get someone like the chap on the right, who I expect would have as good a chance of a good outcome from surgery as I do, and I'm less than half of his age. So focusing on high-risk populations is not the right approach, in my view, because there is this huge potential for bias. We're going to miss high-risk patients in lower-risk categories. Just think about that for a second. And we're going to miss the fact that the highest absolute number of at-risk patients may be in the low-risk population groups. Now, I know that may be slightly difficult to get your head around for a moment, but I'm going to give you an example of what I mean. And the concept that I'm talking about is something called the Rose paradox, named after the epidemiologist Geoffrey Rose, or the prevention paradox is the other name for it. So the familiar example I'm going to tell to you is about trisomy 21 or Down syndrome. And we all know that older women are more likely to have a trisomy 21 pregnancy. We know that the risk of a trisomy 21 pregnancy increases with maternal age. However, the absolute number of trisomy 21 pregnancies is greatest in younger women because more younger women get pregnant than older women. And so even though the percentage risk in those populations means that older women are at higher risk, the absolute number of Downs pregnancies or trisomy 21 pregnancies is higher in the younger population. Now, if we apply the race paradox to some surgical outcome data, this I've adapted this table from the USOS study that was published in the Lancet in 2013 and led by my colleague Rupert Pearce. And you'll see the same phenomenon here. So if we compare emergency surgery and elective surgery, that you'll see here in the second column, the proportion of inpatient deaths within the category was higher in emergency surgery, no surprise there, and nearly 10% mortality, than in elective surgery, which had a 3% mortality, still higher than anticipated, but nothing like as high as emergency surgery. But what's really interesting is that when you look at the absolute number of inpatient deaths, the number of deaths in the elective surgery group dwarfs the number of deaths in the emergency surgery group, simply because of the higher volume of elective surgery that was undertaken. Okay, so I hope I've convinced you that looking at very gross high level population characteristics is not enough. So where are the individualized risk assessment tools, I hear you ask? Well, of course, they are everywhere and nowhere. So let's talk a little bit about the limits of risk prediction. And in order to do that, we really do have to understand population averages. All the individualized risk prediction with a tool like the NISQIP calculator, the surgical outcome risk tool, a cardiopulmonary exercise test, all of these methods, all that they do is reduce the size of the population for which you are estimating a risk. So you narrow your population from the average patient having a Hartmann's procedure to the average patient with an anaerobic threshold of 12 having a Hartmann's procedure, or the average patient with this list of comorbidities having a Hartmann's procedure. And so all you're doing is narrowing the limits of distribution in a normal distribution curve. From on the left there, all patients having an elective AP resection in this case, to on the right there, all ASA3 patients with a set of different comorbidities and cancer having an elective AP resection. And put again, looking at a skewed bell-shaped curve, which is more like the actual distribution of risk in the surgical population. So if you imagine that risk is on the x-axis and numbers of patients are on the y-axis, then all that we're doing by using the NISQIP calculator, a cardiopulmonary exercise test, or anything else, is we're placing a number of little teeny tiny bell-shaped curves all the way along this big one. So there will still be a margin of error in any prediction that any of these calculators put out because they're based on population statistics. And a really, really important thing to remember is that when you get over to the right-hand side of this curve, to the really high-risk patients, because the really high-risk patients are fewer in number, we have much smaller samples to base our estimates on. And therefore, the curves are much more likely to be broad than narrow. So the likelihood that you will over or underestimate the risk in a high risk patient is substantially greater the higher the risk of that patient. So essentially, that's a really important thing to consider when we think about how we use these risk prediction tools responsibly. So what decisions are we going to make on the basis of a risk estimate? Would it be a go, no go on doing an operation on somebody? Would it be about selecting which patients go to post-operative critical care? Would it be to facilitate the patient consenting process? So my view on all of this is that we should never make a go, no go decision about whether or not to undertake a procedure on the basis of any sort of threshold estimate using a risk prediction tool ever. It's a really bad idea on its own. Because if you set an arbitrary cutoff of 20%, we're not going to operate on anyone with a greater than 20% risk of death or other adverse outcome. You're going to get it wrong a reasonable amount of time. We could have reasonable confidence if you work in a system like mine, where often critical care beds are under huge demand and we don't have enough resource available to serve every patient that's turned up for surgery that day. If you've got a tool with reasonable discrimination, then probably using a tool to help risk stratify patients in order to decide which patient gets the critical care bed is not a bad idea, as long as you have confidence that your tool is a good discriminator. And should you use these tools to help in the patient consenting process and the shared decision-making process? Absolutely sure, but only if they get it, only if they understand. The concept of a percentage risk of death or other adverse outcome is pretty hard for most patients to get. If you tell them they've got a 5% risk of death, that to us sounds pretty bad, but to them might sound brilliant. I've got a 95% chance of survival. So the way that the NISQIP calculator presents it, where it says well, this patient's below or above average or about average, is perhaps more helpful for conversations with most patients. The second thing that we want to do is try and understand the other limitations of risk prediction. And there will always be a bit of residual uncertainty because of the patient factors that are not considered in all of these tools. And I saw some comments about this in the chat in between my last talk and this one. So risk models are developed using historical populations and a limited list of variables. And there's always some bias in there because we only include parameters that we can either measure or are easy to measure, or we think are important, or both. And the NISQIP calculator attempts to overcome this with this certain adjustment of risks. And I can see Dr. Bloomstone clapping. And, you know, when I first looked at this, I thought, whoa, this seems a bit odd. But actually, in fairness, you kind of think to yourself, well, there will be a bunch of things that we're not including in this, even a NISQIP risk prediction tool that's pretty detailed, that could materially impact on the patient's outcome. And I've already presented these data very briefly, but when we looked at clinical judgment, compared it against the best risk prediction tool that we could find outside the US, actually combining clinical judgment with this tool to improve the prediction, the accuracy of the prediction. And there are a bunch of things that are not usually in risk models which might affect outcomes. So for example, there are some rare diseases that will affect outcome. Deprivation is not commonly used in risk prediction models in my experience. Unusual surgical complexity is kind of difficult to account for. And patient motivation. I mean, you know, there are some patients you kind of think, yeah, they're going to get through somehow because they're just so motivated. And these are things that we don't normally, we're normally unable to capture. The other thing is that even when we're sure we can predict the outcome, sometimes life surprises us. And there's a whole bunch of different things that can seriously impact on whether or not a risk prediction tool is perfectly accurate or not, because some stuff happens that we would never predict. A patient could get anaphylaxis. They could get the wrong blood because of a mistake in the hospital. They could fall out of bed and have an intracranial bleed, which leads to their death. And these are the sorts of things with rare events particularly, and of course short-term mortality is on the whole thankfully a rare event, that can substantially affect the accuracy of a risk prediction tool. The final thing that I want to touch on is how non-patient factors also contribute to residual uncertainty in the use of risk prediction tools. And that's because when we're chasing a moving target when we use risk prediction tools. Because if you think about the factors which affect patient outcomes, and I'm going to round back, I hope, in a nice circular way to some of the concepts that Dr. Maheshwari was talking about in his talk. We've got patient factors and we've got surgical factors, but perhaps the most important thing is we've got quality of care factors. It's the thing that gets us out of bed in the morning. It's the fact that we think that we can make a difference to a patient by looking after them well. So maybe when we're thinking about patients and reflecting back on whether or not a risk prediction tool did its job or not, when we get the patient with a NISQIP predicted mortality of 15% who had a completely clear flight through their surgery and came out the other side with no problems, we shouldn't assume that that means that the prediction tool doesn't work. We should just pat ourselves on the back and say, didn't we do a great job? So in summary, in my view, all risk estimates are population-based, and the most important consideration is ensuring that both you as the clinician and the patient understands the limits of our confidence in any point estimate. And the higher risk the patient, the more likely that point estimate will have a very, very wide boundary, wide standard error, wide standard deviation around it. And risk prediction, really importantly, should only ever be used to start a conversation and not finish it. It's there to guide us, but it's not there to make absolute decisions for us. And that's where the humans remain really important. Back to you, Dr. Bloomstone. Thank you.
Thank you so much. Sorry about the pups in the background. We have just a few minutes. I want to say thank you once again, Professor Moonesinghe and Professor Maheshwari. I'm going to pick a few questions. Number one, and some comments. We have found that from Richard Prilip, we have found that patients are enthusiastic, even eager to see and discuss the results of menisquip calculated risk in the pre-op clinic. And that relates in my mind to your conversation relative to patient activation. To what extent have you found these tools to be helpful in the patient activation arena?
Is that for me,
Yeah.
Dr. Bloomstone?
Yeah, go ahead.
Yeah, so so do you know what? I haven't really made any attempt to see systematically whether the discussion of risk with patients improves their activation. And it would be a great study to do. Dr. Maheshwari sort of alluded to the fact that we have few impact studies of risk assessment, and that's the big gap in the literature. We know we can predict risk. Now we need to know what impact actions that we take on the basis of that risk have. So I think it would be a great study to do to look at whether even just the discussion of risk with patients improves their activation levels, and whether that in turn then improves their compliance with different aspects of their care.
Thank you. Dr. Maheshwari, Michael Aziz says, is there any evidence that the use of these tools reduces risk even if the variable is modified?
So I think a lot of evidence regarding that. First is the knowledge of if the tools were used in the pre-op clinic or in the intraoperative care. That information is pretty limited. It is unfortunate that at this point of time, we do have flood of literature regarding multiple risk predictive models and showing that, okay, I have the AUC curve of this, or I have good calibration and some values, but their actual use in the preoperative clinic, I think it's still limited to like the ASA score or Malamati score, which I try to allude to, or RCRI, which is used. Like, for example, RCRI is commonly used, at least in our practice, both in the pre-op clinic run by medicine folks and our folks. And we utilize that information for modification into going forward, like cardiology consultations and stuff. And we change our location of care. We change our team, which we do. We change our monitoring strategy, like, for example, troponin monitoring for high-risk cases based on that tool. Did it actually improve outcome out of it, right? By changing this behavior? That still remains to be seen.
Thank you. We may have time only for one more question. We'll see. Dr. Richard Epstein focuses on the issue of the impact of surgical scheduling and production pressure. Documenting use of risk assessment tools is a good suggestion, but where to have this discussion, he asks. I offer that in the holding area after the patient is undressed and ready to enter the operating room is not the time. We don't typically get our assignments until the regular workday before surgery. Should this be done at the time of virtual pre-op visit? But anesthesiologists are often not involved in that process at this point, mostly nurse practitioners. Dr. Moonesinghe, thoughts? And then Dr. Maheshwari.
Yeah, it should. Thank you very much. It's a great question. I think it should occur as early as possible in the surgical pathway. So in the United Kingdom, we would offer it in the preoperative assessment clinic, which is nurse-led, but the higher risk patients are seen by an anesthesiologist. So if you've got a low risk patient coming for a minor procedure, it's probably not so important to have that conversation. But if you've got someone coming for a big operation that's got a risk, I would say a predicted 30-day mortality risk of greater than 1%. I think that merits a short conversation with the patient at least, just to explain their risks to them. And I think you can do it virtually. But as you say, doing it when they're getting undressed just before the operation, it's way too late. So again, we've got to elbow our way into the pathway a bit earlier.
Dr. Maheshwari?
Absolutely agree. I think the improvements in perioperative care to reach the mortality and morbidity figures which we have in the modern world is plateaued right now. Now, the question is, if we want to make further improvements, we have to really change the way we work. And that goes to the fact that, definitely that's not the way of even improving patient care or making those decisions a few hours before the surgery. That goes to the whole idea of the perioperative medicine, that you should be seeing patients a month before. For example, now anemia interventions or even pain interventions like modifying patients' behavior, giving them education regarding what to expect or not. There's whole different fields which have already identified what can be done now. But the implementation of this would require huge structural change, at least in United States practice.
Great. Dr. Moonesinghe, I'm going to end with this last question, which I absolutely love. I've loved all the questions, and thank you for that. With Professor Shrikantha Rao, who asks the following: while risk calculators may predict the likelihood of a certain morbid event as a percent, X%, how do you actually translate that when you're having a conversation with your patient?
Right. I mean, it's a great question. Thank you. And I don't use percentages. I use the calculator. I then present that to the patient qualitatively. And the way that I do it is I do it by saying, you are about average, more than, higher risk than average, lower risk than average, whichever way it goes. And I use other qualitative signals. I am concerned about your risk with this because I consider you to be high risk. Of all the patients that I've seen, you are wherever you are in my experience of risk. So I think people understand worry, they understand concern in the handling of hopefully a sympathetic clinician. And I think that's probably, I hope, a more effective way of communicating than giving them a number that's really hard to interpret.
Dr. Moonesinghe, thank you so much. Dr. Maheshwari, thank you so much. And thank you all for who dialed in this morning, or whatever time it is where you are. I apologize for the 14 other questions which we didn't get to. And God bless you all. Be safe. Thank you so much.
Thank you.
Thank you.
Bye.
Bye-bye.